this is me speaking first. These are my paper notes first. Listen to what I'm saying, and then listen to what I go through in the PowerPoints. All right. So far for Unit 1 is including chapters 1, 7, 8, and 9. These are the things we have reviewed. We have reviewed mental health versus mental illness, the definitions of those. Mental health, your overall well-being. Mental illness, where we have that significant dysfunction leading to full psychiatric disorders. We have the mental health continuum. That is our scale, our range from being on the left side of great overall mental health and well-being, and then dipping off into that dysfunction. At the very right end, we have that disabling or chronic mental disorder, dysfunction going on. So that's on the mental illness side of things. We have risk and protective factors. We talked a lot about the diathesis stress model. Related to the diathesis stress model, we talked about how that points to our genetic predisposition for certain diseases. And we talked about our stress serving as a trigger. So they both have to be present in order to lead to mental illness. Resilience, we talked a lot about with our kids having the ability to adapt, recover, and continue functioning after adversity. And then again, I got on here the diathesis stress model. Mental illness may result when an inherited vulnerability interacts with environmental stressors. We have the recovery model we talked a little bit about, and that's we're focusing on hope, empowerment, meaningful living, and patient participation in care. We talked a lot about mental health stigma. Related to mental health stigma, that's the negative beliefs or discrimination toward mental illness that can delay treatment and recovery. We talked about mental health legislation. We talked about the Affordable Care Act versus the mental health parity. With the mental health parity, remember parity, think equal. So this is equal insurance related to if you're treating chronic kidney disease versus if you're treating bipolar 1. We need to make sure that we are paying attention to those. So that's Mental Health Parity Act and the Affordable Care Act. All right. Any questions?
No.
No? All right. So we talked about the DSM. The DSM, that's like in psychiatry, your manual, your Bible. It has all of the psychiatric disorders that exist inside of it. It has a set of criteria and symptoms that have to be present in order for you to have a certain psychiatric disorder or illness. I told you all that it's very textbooky, but that doesn't mean that your patients won't go outside of like the exact criteria that you see in the book. But it's super important to know it's different versions of it, but it's just our standardized diagnostic criteria for psychiatric disorders. So chapter 7, we talked a lot about the nursing process. We talked about the psychiatric nursing process related to assessment, diagnosing, planning, implementation, and evaluation. It is super individualized in psychiatric care. We talked about the mental status exam. We're going to continue to talk about that. We talked about the overall psychiatric assessment being the comprehensive evaluation of biological, psychological, social, cultural, spiritual, and environmental influences are all a part of that psychiatric assessment. We have certain age-specific considerations we must look at when we're talking about the young and the old. We really want to meet our patients where they are related to their age and whatever developmental stage that they're at. We talked about nursing diagnoses, outcomes and planning, documentation, legal and ethical considerations. QCIN, we talked about multiple times, which is like that body that does that national initiative related to quality and safety. For chapter 8, we just talked about therapeutic relationships, therapeutic use of self, nurse-patient relationship, social versus therapeutic relationships. We talked about professional boundaries, transference, and countertransference. Know the definitions of those. What does self-awareness look like? Peplow's phases, the pre-orientation phase, orientation, working, and termination, therapeutic communication, verbal versus nonverbal communication, and then the breakdown of all the things related to active listening, silence, reflection, clarification, open-ended questions, non-therapeutic communication, which is, we don't give advice, we don't ask excessive questions, we don't put our own personal bias into our communication with our patients. And we talked about cultural considerations. Any questions?
No.
All right. Okay, so this is pretty much the visual of what I just said. Some of the visuals. So remember, you're seeing it again. All right, the mental health and mental illness continuum. Any questions?
No.
All right. Quality and safety education for nurses, your national initiative body, the people who make the exams. I told you they have the 6 competencies that everything we do in nursing kind of stems from. All right, this is just a picture related to epidemiology, that's talking about the disease, where did the disease come from, when did the disease come about. When you talk about incidence, it's important for you to know what the definition of incidence is. When we talk about incidence, that's new cases of a disease. When we talk about prevalence, that's your new cases plus your old cases that existed. But when cases of a disease or process, it goes to recovery, they come out of that prevalence, so they're no longer there. So they're kind of subtracted from the prevalence number. And then you have, of course, the disease that leads to death. So those terms, you should be familiar with what those terms mean. Excuse me. All right, your mental status exam, again, know what's inside of your mental status exam: appearance, behavior, speech, mood, disorders of the form of thought. So here is not really giving you the details yet. Like, we will talk more within the semester about what does a patient who has flat affect look like? What does the term euthymic mean? When patients are experiencing decreased cognitive ability, they're no longer alert and oriented times 4. We'll talk about mania. We'll go into all the detail about that. But in general, this is something, these sections are good for you just to kind of know general information about. All right, legal considerations for documentation of care, the do's and the don'ts. We talked about that. Charting in a timely manner, making sure the information that we chart is fully factual. Chart what you see, hear, feel, and smell. We're not charting on anything that we did not assess. We do not want to put our personal opinions into the charts. We do not want to chart before an event occurs. We do not want to chart generalizations. We don't want to leave blank spaces for chronological notes. Incident reports, we know go in the incident system. All those things are super important. But remember, this is a box. So if it's a box, it's probably present in your book. So that's chapter 7, box 7.6. All right, social versus therapeutic relationships. Social relationships are the relationships that really lack the boundaries. It's the friendship, the enjoyment, the relationships we are not to have. Therapeutic relationships, that's where we have our boundaries. That's where patients' needs are actually being addressed. The language is straightforward, and we're here to focus on the patient's ideas. All right, Peplow's model, again, the know the phases is here. All right, 4 zones of proximity. We talked a little bit about that, and it really describes, I said earlier, how people use personal space during communication. In psych, we know that we all need a certain amount of personal space for safety. When we're doing assessments, we are a little bit closer, but if a patient is choosing to have quite a bit of distance from you, it is for a reason. So I would tell you to look into what each of these zones mean. What's the difference between intimate and personal, and then personal versus social and public, which is like 12 feet of space. Look into those zones of proximity or proxemics. All right, the do's and don'ts again. We don't argue with our patients. We don't give false reassurance. We do not try to sell the patient on accepting treatment. We want to remain focused on facts, make observations of the patient's behavior. Change is always possible. We want to listen attentively. Those are all things we should know within nursing, those things to do. Encourage the patient to look at the pros and cons. All right, therapeutic communication again. Same thing, silence is a technique, accepting, giving recognition. Pay attention to therapeutic communication techniques. Same thing, reflecting, restating, focusing, seeking clarification. Same thing. More summarizing, suggesting collaboration, attempting to translate into feelings, pay attention. Non-therapeutic communication, we just talked about that. The minimization of feelings, false reassurance, making value judgments, asking why questions, giving approval or agreeing, disapproving, disagreeing, changing the subject. And that's the end.